me is that he was the founder of the Australian College of Nutritional and Environmental Medicine. And when I worked in Australia, he was the guru of intravenous therapy, and we'd all trot around the country going to wherever Ian was going to give another workshop. So he set up several clinics all over Australia, and he became very infamous over the HIV pandemic for his treatment of HIV patients who were treated very, very successfully with his protocols. So without further ado, I would like to move on to the management of cancer. CP is working with the Golding Institute. He is a herbalist and a traditional doctor there. And I've certainly just come off a consultation with a patient with CP, and his knowledge of how to treat cancer is quite mind-blowing. So I'm looking forward to hearing what you both have to say, and we'll kick off with you, Ian.
Thank you very much, Jackie, and hello, everybody. As Jackie said, I have quite a lot of experience with vitamin C, intravenous in particular, and it started really back in the late 1970s when I'd come back from traveling around the world looking for other ways of helping patients. And I'd heard about Linus Pauling and his work with intravenous vitamin C in cancer in the US, and his books about vitamin C and the common cold. So I was prescribing diets and vitamins nearly from the beginning when I graduated, because my background in agricultural science told me that we look after the nutrition in the soils, crops and pastures and animals and productive animals, but we didn't do it with humans. And so I decided I was going to be a different sort of doctor and prescribe diets and supplements. And lo and behold, the results that we were achieving were quite remarkable in patients who were not responding to orthodox treatment. So my experience with vitamin C IV was initially with acute viral illnesses, including the common cold and influenza, also herpes, shingles, herpes zoster, herpes simplex, both 1 and 2, glandular fever, infectious mononucleosis. In fact, the results with infectious mononucleosis are absolutely incredible if you get the patient early enough, and you don't end up with people with chronic fatigue syndrome, or MECFS as it's called. And then lo and behold, of course, patients come along not feeling well and with cancers. And one of my first experiences with a patient with cancer was a gentleman who was told within 2 weeks to 4 weeks his bowel was going to obstruct because of the cancer and its rapid rate of growth. And he didn't want it. He was 70 years of age. So he pleaded with me to give him intravenous vitamin C. And I started off with 1 gram. He said more, 2 grams, more. I kept on doubling it until we got to around about 20 grams. And I was getting very nervous because this was one of the highest doses I'd used. And this is back in the early 1980s. Lo and behold, his bowel started functioning better. His appetite improved. He gained some weight. He felt better, more energy. His bowel did not obstruct. 2 months later, he was had a lot more energy. And this gentleman went on to live for another 5 or 6 years, 6 or 7 years. And he passed away from old age rather than the bowel cancer. And then the advent of the HIV/AIDS virus in the early 1980s saw others wanting help. And I couldn't say no. And we started giving high-dose intravenous vitamin C, taking patients off the AZT that Anthony Fauci was recommending in the US. Patients on the AZT were dying. Patients off the AZT on the high-dose intravenous vitamin C and other nutrients, of course, were surviving, and I was very surprised. And in fact, patients with Kaposi's sarcoma, the Kaposi's disappeared or regressed, if there was many of them. And so the pneumocystis carinii pneumonia patients were quite responsive to the high-dose intravenous vitamin C and other nutrients. And in fact, sometimes they would have 2 or 3 episodes of pneumocystis and still not succumb to the disease. And it was fascinating to see these patients get better. And I've still got some old videos of the patients who were had given television interviews and survived. And it was at that time when I became infamous because I wrote that book that Jackie just put up. And the medical board didn't like the book. They didn't like the fact that I was appearing on television and appearing in the newspapers and on the radio. So I was accused of infamous conduct in a professional respect, which is the most severe charge that allegation you can be charged with in Australia at the time. And they tried to strike me off, of course. And anyway, I beat that in the Supreme Court. It's a long story, and I basically cut it short. I won the case in the Supreme Court, beat the Victorian Medical Board, and they had to pay my costs, which back in the 1988 were around about $200,000 or just over. So it was a success. And after that, we managed for the next 20 years while I was president of the college I'd started to create a very safe and environment in which doctors could practice what we called nutritional medicine, because originally we called it orthomolecular medicine after the late 90s Corning, but we changed the name to nutritional medicine to attract the medical profession and the nutritionists to do the courses. So the highest dose that I used with one of my Kaposi's sarcoma patients in a 24-hour period was 220 grams. It was a record at the time, and I don't think it's been broken very often since. We've been involved in all of the pandemics or epidemics, I should say, the influenza, swine flu, bird flu, and the others since the 1980s. And there is a video that I think Jackie may have available of a dairy farmer. And this is not a cancer patient. Well, sorry, it is a cancer patient, but it was a patient with swine flu in New Zealand who was on ECMO, extracorporeal membrane oxygenation, for 6 weeks. I think it was 6 weeks. It may have been a little bit longer. And he had lung whiteout. He had renal failure. His kidneys had shut down. He was on the extracorporeal oxygenation, and he had hairy cell leukemia. And all of the experts who were consulted around the world said this man would not survive. His family took legal action against the hospital, insisted on high-dose intravenous vitamin C. I was contacted by one of the family and one of the friends, and I think there were other physicians who were involved in it, but we recommended 100 grams. I didn't think it would help this gentleman, but he received 100 grams daily, IV, of sodium ascorbate. And surprisingly, he came off ECMO and he's still alive today. And that's, I think, 12, 13, no, probably 14 years ago now. And he swears by the high-dose intravenous vitamin C. Another patient of the same illness, the same time, had swine flu, was on ECMO in St Vincent's Hospital in Sydney, Australia. And this lass came off ECMO as well. She was in a very bad state, but they stopped the high-dose intravenous vitamin C, and she succumbed. She came off the ECMO, was doing reasonably well, but she had pancreatitis probably caused by the drugs given in intensive care. And she was taken off the vitamin C after she came off ECMO against my advice, and she passed away. So the lesson here is, if you've survived a severe illness with high-dose intravenous vitamin C, don't stop it suddenly, wean down slowly. And it brings us to COVID. Oh, by the way, the dairy farmer who survived, who had the hairy cell leukemia, his hairy cell leukemia disappeared as well. So now we're looking at Professor Ronaldo Belamo, who treated one patient in late 2020, one COVID patient who was deteriorating quite rapidly. with 30 grams of intravenous sodium ascorbate. And surprise, this patient was heading seriously towards serious sepsis. And I mean, that's a fancy name for a severe hyperoxidative state in multiple organs, not all organs. And I call it a massive deficiency of the redox reagents that we use. And redox reagent we're using is sodium ascorbate or vitamin C. And Professor Ronaldo Belamo stated in the media here that the response was remarkable. Since then, there's been no high-dose intravenous vitamin C given to COVID patients, to my knowledge, in intensive care in Australia. And this is a shameful act. I have argued intensively with intensivists, with barristers for the patient and barristers for the hospital, to the point where we see patients who need it slowly dying and passing away as a result of a lack of the vitamin C. It is a disgrace. As far as I'm concerned, I make a judgment on my profession at the moment. They're just following protocols, and I've had arguments with the intensivists. Are you looking after your patient, or is it just important to follow the protocols? And it's with the protocols who win, not the patients. Even a Supreme Court judge one night, before midnight, just before midnight, was on a Zoom with us, trying to argue, trying to find a reasonable position with regard to the two barristers who are arguing the case, one for the patient, one against the patient. And the one against the patient, the one for the hospital, actually won the case. But here, I might add, there was a patient with severe COVID and on a ventilator. He'd been in a lot of pain, swallowing a lot of paracetamol, and his liver function tests were all over the place. So we suggested that they give him some N-acetylcysteine, and they gave him the proper dose of N-acetylcysteine, and surprise of surprise, instead of succumbing to his COVID, he managed to get off the ventilator and out of intensive care and survived. So there's more than one way of skinning a cat, so to speak, or saving a life, I guess. But I would have preferred the intravenous vitamin C, because I think the patient would have done better in the long run. So ever since we came out with the vitamin C de-zinc campaign at the beginning of the pandemic, the Health Minister, the Prime Minister, and the Chief Medical Officer took no notice. The AMA took no notice. The RAC, the Royal Australian College of General Practitioners, took no notice. And it remained the same, although over the last weekend, previous weekend, we had my old college, the College of Nutritional and Environmental Medicine annual conference. It was titled Long COVID, and there was some expose there, although the doctors are still very frightened to talk about vaccination reactions. And one of the leading doctors actually said that we still needed to mask up, social distance, and continue the vaccines, even though she was severely vaccine damaged. On the same weekend, the Australian newspaper, and I don't know if you got it, Jackie, but I sent out a Substack with the Australian newspaper, which is our national newspaper. On the front page, a picture of Anthony Fauci, and some of the truth is now emerging that Fauci hid the science away from the world because of his, say, his reputation and that of the National Institutes of Allergy and Immunology Institute in the US, or NIAIDS. So we're talking about cancer. I'm happy to take questions or be guided as to what you want to hear now. Thank you.
Well, I think that was brilliant, Ian. But I think the thing is that while COVID and while sepsis and while all those ICU things that happened in 2020, 2021 responded to IV vitamin C, and I actually found I never gave more than 15 grams of IV vitamin C, but I probably wasn't seeing them as critically as you were. and I'd give up to 2 grams of NaC in the same syringe. And it was nothing short of incredible how quickly very sick patients turned around. But then we've moved, fortunately not in Zimbabwe because we don't have mRNA vaccines, but we seem to be moving into a world where I'm seeing a lot of patients who are contacting me and saying that they are having some very unusual cancers, some very aggressive cancers, reactivation of previous cancers. And we saw one of these cases this morning. He has pancreatic cancer, and CP explained to me, and I'd love to hear your opinion on this again, CP, is that intravenous vitamin C actually acts almost as though it rusts your tumor. And I'd love to hear you explain that again, because I was intrigued, because in my mind, it's always been an antioxidant. But from your point of view, can you tell us how you think it works?
Sure. So, like I also said this morning in the consultation, I'm not a medical doctor. So the pictures that I see are slightly different to what one is taught in med school. And the peroxidation process of vitamin C towards cancer, the beautiful picture is that I see that the vitamin C makes the cancer cells rust. It's not 100% correct, but it's a beautiful picture to share with your patient on what is this thing that you're giving to me intravenously is actually doing. Now, vitamin C is an antioxidant, true halfway. When you go high dose, 15 grams upwards, then it becomes a pro-oxidant, and that's where the rusting effect comes in. And it doesn't just fight cancer. It also, it builds the immune system of the patient. It helps them to feel better. It helps the patient with that. We see slightly less pain as well in many of our cancer patients. So vitamin C is not just there to go and fight the cancer, but it has a host of different things. And I think that's one of the important things when we look at integrative medicine as a whole is one nutrient or one agent has many different facets to it. And so we don't just go in and say, let's take over the function of the immune system. Immunotherapy, the beautiful new buzzword that's being used by oncologists, that's been used for many, many years by the less traditional or the integrative practitioners, says, let's build the immune system strong and then let's activate it. Now, something that we love doing here alongside the vitamin C is, of course, then to add a bit of vitamin K3. And that enhances the cytotoxicity towards cancer 10 to 50 times. So you then don't have to go those very, very high doses. We have gone 60 grams, 100 grams, depending on the patient. But now we can stay quite comfortably at 15 grams of vitamin C, plus then the K3, which then enhances the cytotoxicity. Again, depending on the patient, of course. So vitamin C is almost a go-to when we practice or when we see our cancer patients. If they have a normal G6PD, of course, and we need to check that and make sure that if we are going to give over 15 grams, that their liver function is kidney function. Kidney function is fine with that G6PD. So load the body with ammunition, load the body with oxygen, and then use that oxygen with the vitamin C to rust the cancer.
And you know what, I was fascinated with what you said this morning, because I hadn't looked at the peroxidase system before, although I've been having a little look at it in the last half hour on Google. So one of the things that, Ian, you're very clear on in your general cancer protocol. And thank you for that, because it has made a huge difference to at least 5 of my patients' lives. You speak about giving intravenous vitamin C with hyperbaric oxygen. And we've actually delayed someone's hyperbaric oxygen in order for them to receive the vitamin C before they go into the chamber. Our chamber isn't big enough to give it while they're in there. So is this part of the reason? Because CP, you've spoken about ozone therapy, and so the vitamin C given together with hyperbaric oxygen, can you explain how we perceive, or maybe Ian, you can explain the mechanism of how you see that work?
Sure. Look, I agree with CP with regard to the rusting. I also add rancid. So we tell that we actually have cells that go rusty and rancid. And it's part of the aging process, going rusty and rancid, over-oxidation, if you like. And I don't talk about antioxidants so much now as talking about redox reagents, because it's oxidation reduction. You know, it's transfer of electrons from one molecule to another molecule. And if they're electrons that need to be removed from the system, they're dumped into a protein or into vitamin E or some other antioxidant. So we talk about redox reactions. And if you're looking at it from that perspective, Jackie, you put somebody in an oxygen chamber and they'll start producing oxygen radicals, superoxides and hydroxyl radicals. And so the vitamin C mops them up and takes the electrons and shifts them in the direction that they need to go, so that the energy is being used to kill the cancer cells and also help to nourish the normal cells and with oxidative processes, because the cancer cells cannot handle the radicals anywhere near as well. So it's a form of selective chemotherapy, but it's beneficial chemotherapy because the vitamin C stimulates your killer cells, your natural killer cells, the CD4, the CD8 cells, stimulates antibody production, stimulates the cytokines, the positive cytokines, so that you get an improvement, as CB said before, in immune function. So it's a two-edged sword, and it's a benefit to the cancer patient's normal cells, as well as causing oxidative changes in the cancer cells, and it also helps the macrophages and the other cells of the immune system to destroy the cancer cells that are breaking down. And it also helps to stimulate the enzymes in the liver and kidney, the detox enzymes, to accelerate the detoxification process, so the patient is not made too sick. Because if you do too much at once with these patients, they can get sick and feel weak and so on. And I agree with CP to a large extent. Other factors given with the vitamin C help tremendously. And for example, with pancreatic cancer, I give very high doses of selenium because the evidence is that cancer of the pancreas can be, and pancreatitis can be helped with selenium as well. We also look at the circulating tumor cells with a liquid biopsy to see how many circulating tumor cells there are, because that can determine the prognosis with respect to metastases. And the circulating cancer cells or circulating tumor cells can be assessed for their sensitivity to orthodox chemotherapeutic agents, as well as the non-orthodox chemotherapeutic agents, for example, vitamin C, vitamin D, curcumins, and so on. So that's a very valuable way of assessing the patient as well. I think that there is a lot that we can do in the early stages as well as the late stages for cancer patients using nutraceuticals and using them wisely and using them scientifically. There are some things we don't use scientifically in a lot of cancer patients, but we support them with their lifestyle. And it's important also to consider things like meditation, breathing exercises, and also cycling. I think it was Demio, a German researcher a long time ago, put his patients through exercise while they were having chemotherapy. It showed quite clearly somebody lying supine in bed with a pair of pedals pedaling was able to reverse their deteriorating blood pictures, blood films, and liver function tests simply by exercising. And it reduces their requirements for transfusions and so on. The recording stopped.
Right, can we continue to record? Pride, CP had to leave. Pride seems to have fallen off, so we can relax for a bit because it's not being recorded.
Okay.
I'll tell you an interesting story about a pilot who, by the time they'd done, you saw that imaging. Now, the interesting thing is that pilot developed. Are we back recording, Pride? Sometimes we have challenges with electricity in this part of the world. Great. So sorry about that. We dropped out for a couple of seconds. The selenium, certainly I have seen in a patient with a liver tumor that seemed to make a significant difference. Also tocotrienol as opposed to vitamin E. And I think a lot of patients get confused and take these huge doses of vitamin E. And actually the tocopherols inhibit the absorption of the tocotrienols. And that also seems to be very good in the management of these patients with liver cancer. The story I'll tell you now, I sent you the images when I very first saw him. He is a pilot. He has been monitored since 1999 because he did have some abnormalities of his portal vein. So he's had liver imaging. He almost certainly had a neonatal thrombosis. So he's had this portal hypertension his entire life and now has a big spleen and some thick varices as a result. So he was intensely monitored up until now. And in January 2021, he's a factor 5 laden, and he wrote into the airline and said, I really don't think we should be jabbing me. And they said, no, you'll be fine. And he promptly got a groin to ankle clot within 8 days. And then following that, they injected him with Pfizer because he had to be double jabbed to fly. And from then, his liver function started to go off. And he was diagnosed with cirrhosis and a 17-centimeter tumor in the liver. Now, nobody has ever seen cirrhosis develop over a period of less than 18 months. And so this is we are going to write him up. But what was interesting is I gave him a huge nutraceutical panel, keto diet straight away, off all sugar. He also went on to CD zinc in decent doses. He could not get intravenous vitamin C where he was. We put him on selenium at 1,000 a day. I've never put a patient on selenium 1,000 a day. But I kind of went, okay, it's in Ian's protocol. He went on to magnesium as well. And we put him on 1 milligram per kilogram per day of ivermectin. And the thing that I'm finding very interesting, and there were other things that he was put on, and I'll get on to why that's important in a second. But the important thing was, between that first scan, they didn't know quite what to do with him. So they decided to do a PET scan to make sure it hadn't gone everywhere. Then they did a CT chest, abdomen, and pelvis. And then they did an ultrasound scan where they attempted a biopsy, by which stage it had shrunk significantly. And all they got on the biopsy was necrotic tissue, which was very, very interesting because this thing had gone from 0 to 17 centimeters in a year. And now it was shrinking and the biopsy was showing only necrotic tissue. Having said that, they did another biopsy in which they showed that there were definitely liver cells there. There were cells with a high nuclear to cytoplasmic ratio, suggesting that they were cancer cells. His AFP was always negative, so it wasn't a hepatocellular carcinoma. Or it's the first AFP negative hepatocellular carcinoma we've documented. But the most important thing was that there were hardly any mitotic figures. This looked like a very low-grade indolent cancer, and a little bit like CP said earlier, and I don't know if he said it in this discussion or in the previous one, it's not the cancer that kills you, it's the metastases. And if you can contain it and turn it into a chronic disease, even if it grumbles along not metastasizing for the rest of your life. And he said he was very cross with a friend of his whose cancer got completely under control, who ended up dying of a head injury in a car accident 2 weeks later after he was almost cured. But at least he died quickly as opposed to an agonizing chemo radio cancer death. I think the other thing I want to say about this particular patient is that a lot of people perceive that we as doctors who are integrative are against allopathic medicine. We are not. This patient had what's called TARE, which is transarterial radio active embolization. So they got into the bottom of the tumor, they put radioactive material into the things that were feeding the arteries, and they basically cut off its blood supply. And so it's not as though we're saying only take high IV vitamin C, but if you add these things to the patients, they feel so much better and they get better. And the thing that I'm always amazed about is people come off an IV vitamin C and an IV NAC drip, go into the oxygen chamber, and they come out feeling exactly the opposite of how they feel when they come out of chemo. I don't know if that's been your experience.
Yes, it has been, Jackie. I think you're quite right. There are times for both. There are times when either or need to be backed off with regard to orthodox allopathic medicine and the integrative approaches. The integrative approaches are mostly to keep people healthy and well and assist their body to heal, and whatever healing means with regard to wounds or cancers or infective processes or inflammatory processes and autoimmune processes. We can relieve the stress on the biochemistry of the body with the nutrients and the IV vitamin C and diets and enemas and saunas and near-infrared light. So many things that we can do to improve physiology and the patient's well-being. And it's always here where the art of medicine, rather than just pure science and technology, is so important in looking after the patient. You know, I had somebody who had gone through all of the surgery, 3 surgeries and 2 series of radiotherapy for a grade 4 astrocytoma. He was given 2 weeks to 2 months to live. And we did all of the things, including massage and diet, and mistletoe injections and intravenous vitamin C. And I was surprised because 3 months later, he came back and he was as normal as you and I. He'd been aphasic and ataxic with the tumor. And I thought, this is unbelievable, because I didn't think things would have helped, anything would have helped him. And the tumor in his brain had walled itself off. And every year he goes back and has a scan at the McCallum Institute here. And they see the tumor, they see it's not done anything, it hasn't metastasized, it's stayed there, and he's living happily and healthily with it. So that's a situation where he was, you could say to all intents and purposes, cured. But another patient, they come back with a recurrence of a cancer and it needs surgery or radiotherapy, then I'm happy for it to go ahead, providing the patient stays on the health promoting aspects of what we're doing. Yeah, see the slide you just put up. I mean, vitamin C in the critically ill. It's something I was very, very fortunate and privileged, I think, to have access to 4 hospitals. There's no other nutritional medicine doctor in Australia who's had access to hospitals like I have. And that's where I was able to get informed consent from patients and do little experiments like food challenges and fasting and intravenous vitamins and intravenous nutrients and so on. That was a massive learning curve for me, having the patients in hospital where I could monitor them closely with regard to the nutritional interventions that I was making.
So, Ian, one of the things when I was sort of promoting ivermectin quite heavily, my question was, it's so safe. If not, why not? I mean, what's the worst thing you're going to do? I know of one ivermectin patient who's actually died from taking ivermectin, and he drank 660 mils, which is 6.6 grams of it. And he did it as a suicide attempt, and he combined it with alcohol and warfarin, and he eventually died 18 days later of an aspiration pneumonia. The ivermectin had worn off. I've never seen any significant adverse effect. Have you ever seen any significant adverse effect with IV vitamin C?
No. Well, it wasn't in my clinic. It was in a clinic. There's two cases in Australia that I'm aware of where vitamin C has been a problem. One was in a cancer patient in Sydney who'd been taking intravenous chemotherapy, and that intravenous chemotherapy was a potential agent for kidney stones, renal stones, and the patient was also given intravenous vitamin C. And they blamed the intravenous vitamin C for the kidney stones. I, in my heart of hearts and my mind, believe it was the high dose of the chemotherapy that caused the stones. But of course, the vitamin C will always get blamed because it's always been claimed that it will cause kidney stones. Well, we know now that vitamin C reduces inflammation and the propensity for kidney stones, renal stones. And it can be used with magnesium and vitamin B6 to reduce the incidence of renal stones. The other was a case in Melbourne, and again, it was somebody with a deficiency of G6PD, glucose 6-phosphate dehydrogenase, the enzyme, and they were given 60 grams straight off. Now, in my clinic, we never tested for glucose 6-phosphate dehydrogenase deficiency. We never went up to that level without, sorry, I'm getting my words mixed up here. We always gave up to 25 grams or even 30 grams without testing. But if you go up as high as anything higher than 25, 30 grams, there is a risk with G6PD deficiency. So I think we have to be wise, and this particular case was given a high dose, 60 grams of vitamin C, and the G6PD deficiency test came back that there was a deficiency, and this particular patient had a hemolytic crisis. It was managed. There was no serious sequelae, but it was very, very embarrassing for the clinic that did it. So there's only 2 cases. I did 250,000 IVs over a period of 10 years. I think I prefer to, according to the patient, I prefer to have kidney stones than to be dead with a head stone. That's one of my favourite sayings, actually.
Yeah, that's your slide. Now, one of the things I'm really interested in, because we've neglected HIV so much over the last 3 years, we really are seeing problems with it in Africa at the moment. And I'd love to hear your experience of using intravenous vitamin C in HIV patients. When would you give it? Would you give it when they were very ill? Would you give it as a regular infusion once a month? How did you manage your HIV patients?
Well, unfortunately, my HIV patients usually came along when they had full-blown AIDS. So I was managing full-blown AIDS most of the time with my patients. And after my Supreme Court case, I took the advice to be careful with treating the HIV/AIDS patients, because it became political, and it could have occurred again where I faced the medical board after the Supreme Court case. There was less risk, but I managed to take the patients and hand them over to other doctors to look after. I made sure that they got my book and they kept going on my protocols. I made a big mistake back in the early 1980s, mid 1980s, with my HIV AIDS patients, and that was I did not give them enough vitamin D, and I wasn't aware of how important vitamin D was in the immune system at that stage. I mean, there's been a lot of research work done since the 1980s to support high-dose vitamin D in autoimmune disease, HIV, cancer, and so on. So that was my big mistake with my cancer patients, my HIV patients, that I did not monitor and put them on high enough doses of vitamin D. If you have a look at my book, you'll see everything is there, including sunbaking. But again, I think if I'd used more vitamin D, my AIDS patients, instead of surviving a prognosis of 11 months and going on to live for 7 more years, I may have got better results than that. But having said that, it was a learning experience for me and for my AIDS patients. And if the authorities here had taken notice of what we were doing, we would have had no such thing as a coronavirus pandemic now. We would not have had the pandemic, because everybody would be given public health information about the value of vitamin C, D, and zinc. But I think maybe this time there is an opportunity for us to take that message to the rest of the community. So if I was in treating a population of HIV patients, Jackie, the first thing I would do, as soon as they were diagnosed, would be giving them at least 14 days, perhaps even more, of high-dose intravenous vitamin C to try to reduce the effects of the virus, direct and indirect, and maybe even with the vitamin D, prevent the reverse transcriptase from acting and inserting the viral DNA into the genome. I don't know. It's just conjecture.
It certainly wouldn't do any harm.
Certainly
I'm in the process at the moment of trying to get vitamin D injections in here, 300,000 to 600,000 units, with the idea that if we were to inject everybody at the beginning of winter, then we probably wouldn't have any issues with all the respiratory viruses, whether it be influenza, respiratory syncytial virus, COVID, any of them. And it would cost us $1.95 landed for 600,000 international units, which if we went down to the HIV clinic, which is at the Center of Excellence at the state hospital here, we could inject those people and they would be vitamin D sufficient for the whole of winter. Anyway, I've come across a few little regulatory hurdles, which I am currently wangling my way around. But what I find it absolutely fascinating is that trying to get through injectable vitamin D made by Abbott into Zimbabwe, into that situation, is much, much harder than getting in drugs like remdesivir and these other highly toxic drugs. So, I know that obviously some of the people funding the big pharmaceutical companies are in the business of not keeping people well, but potentially keeping them sick. But literally, if we've got 1.4 million HIV positive people in this country, for probably $3 million, we could dramatically improve their outcomes, including TB. We lose 400 people a month to TB as a result of HIV, and we could stop that for $1.95 a patient.
You certainly could. I mean, back in the days before we had all of the drugs for TB, the patients in the TB wards would be wheeled out in their beds to soak up some sun. And one of my lectures I've given recently has got pictures of patients in the hospitals, in the chalets in Davos in Switzerland, lying out in the sunshine, getting the sun, because it was known back then empirically that exposure to sunlight actually reduced the severity of the tuberculosis and improved the prognosis. And why the sunlight? Well, it's the vitamin D, of course. It does help with other things, but the D is the critical one. And I agree with you wholeheartedly. It's a paradox that you can bring in remdesivir into a country, but you can't bring in vitamin D into a country, especially with coloured people who have very, very significant difficulties in producing enough vitamin D to protect themselves.
So well, the last thing I'd like...
You're a pioneer, you're a champion, but keep it up.
The last thing, I now have a scholarship. And it's a scholarship to learn with you and Kylie O'Brien about 55 modules of cannabis and cannabinoid medicine. And I'd just love to end off with hearing what your journey has been using CBD and cannabinoids in HIV, in cancer, in COVID, because I know you sent me something to show that nebulized, and I gave it to some patients, and there's no question that they got better, especially if I combined it with silver. So what I'd love to hear is your whole take on cannabinoids, and I have to share my favorite screen share of all time. Now, I think it was you that taught me that the alcohol and the let me just share, and the tobacco industry banned cannabis. And I have to say, I've seen a lot more people die from alcohol and from smoking than I ever have seen people die from cannabis. I have seen demotivation syndrome. I have seen people who smoke it become psychotic. I think it was you that said if it's ingested, you don't get psychosis. But this is my favorite Ian Brighthope slide of all time. And I would imagine more people have died from vitamin C, ivermectin, and vitamin D that have also been gored to death by unicorns. Yeah, exactly. But I would love to hear your opinion on cannabis as we end the session, because we've got about 7 minutes left.
Okay, well, very quickly, I was very interested in it when I was a student. I was very interested in MDMA and the psychedelics, including psilocybin. But when I met Olivia Newton-John's latest husband, Amazon John, Olivia and he introduced, because he was spending a lot of time with herbal medicine, plant medicine in the Amazon. He was called Amazon John. He was very interested in these herbal medicines, these plant medicines for mind functioning. And he took me through the ayahuasca, the trips that people have in the Andes and in Peru, in the jungles, and become spiritually different, resetting their brains, separating old memories and painful memories. These stories got to me. So I studied a lot about cannabis 15 years ago and what it did. And I don't approve of smoking it because you end up with byproducts of in combustion, and these byproducts are toxic, and that's when you get the harmful effects of marijuana and marijuana smoking. But cannabis itself, as a plant, as an oil, as a plant chopped up and put into a salad or into a drink, is harmless, and it's less addictive than tea and coffee. And as that slide shows, and that's a very good slide because it's proof that cannabis has never, ever killed anybody. Yes, people might overdose with alcohol and jump off a building at the same time as smoking a weed, but that's not the cannabis causing the death. The oral use of the oils is brilliant, and is brilliant from the perspective that there are so many indications now that have been approved of because of the science behind it. For example, pain, cancer pain, non-cancer pain, neurogenic pain, all sorts of pain, anorexia, nausea, vomiting caused by chemotherapy or chemotherapy-induced nausea and vomiting, Dravet syndrome, which is an intractable form of epilepsy in children, you name it. But because we're not treating the disease, we're treating the patient, we're treating the patient's endocannabinoid system. Our own systems, our nervous system and our immune system cells produce cannabinoids, endocannabinoids. Some of them are well known. Anandamine is one, and 2-AG is another. So these endocannabinoids are produced by the bulbs of our nervous tissue, and that they are signaling molecules. They talk to one another. They downregulate impulses in the nervous system. In the nervous system, they also help to take messages from one system to another system. They're virtually in every cell in the body. So we are actually managing the endocannabinoid system in patients with all of these conditions, whether it be epilepsy or cancer or pain, or post-traumatic stress disorders, and severe insomnia. And we did a study last year on severe insomnia. And not only does it help, this was a study with 10 units of THC or tetrahydrocannabinol, and 15 units of CBD or cannabidiol. We found that the sleep improved, the quality of life next day improved, but not only that, people became more productive. And the most important thing that I found, or we found in the study, was that their pineal gland produces more melatonin. Melatonin significantly increased during that period of sleep on the cannabinoids. So that tends to stimulate my thinking that we need to start using it for treating cancers themselves. But a lot more research work needs to be done in this area. But you do find, Jackie, if you can relieve the anxiety, and that's another reason we use it for anxiety, if you can relieve the anxiety in cancer patients and get better sleep, they have a better prognosis, they have a better quality of life, and you get them off the opioids. I mean, we had one patient who had severe pain on 3 opioids, paracetamol, antidepressants, and sleepers. And she came off everything apart from the paracetamol occasionally. When you see results like that, you have to say, well, do we need to say no until we've got more studies, or do we start saving patients' lives and start saving patients' pain syndromes and stress, and use something that's given to us by nature, that's been made illegal by the United Nations back in 1937, because it was interfering with the ordinary pharmaceuticals, the pharmaceutical industry. I think we now see large numbers of patients in Australia on medicinal cannabis, and simply a couple of drops of oil, maybe once, twice, 3 times a day. And they function normally. They live normal lives, pain-free, stress-free, they sleep well. It's a godsend. And let nature be nature. We cannot, with all of our knowledge, become arrogant and believe that we, in modern medicine, modern science, can cure all, because we can't. nature's got some fabulous answers to our problems. So I encourage everybody to learn about the endocannabinoid system, because that's what you're treating. You're not treating the disease, you're treating the endocannabinoid system. And that's why this is an art in medicine, because everybody is different. One size doesn't fit all. So some people might need 1 drop at night time, others might need 3 drops in the morning and 2 drops in midday, or somebody might need a treatment once a week or once a fortnight. It's incredible what this substance can do, and it's a learning experience for the patient as well as the physician. So I think we need to see more research done on the cannabinoids that are specific for certain cancers, like there's work being done on prostate cancer and breast cancer cells. That's in vitro work at the moment. But you do find that patients who are on the medicinal cannabis are easier to manage, their pain's easier to manage, the chemotherapy-induced nausea and vomiting disappears. Sometimes you've got to use a vaporizer, but that's not smoking it, that's not producing combustion products, which are psychotoxic. The cannabinoids, in the right usage, are not psychotoxic, they are psychoactive, and they are psychoactive in a beneficial sense. So, and you can't overdose with it. You could have a huge room full of cannabis, and you could smoke it for as long as you like, but you end up with couch lock and basically lying on the couch looking pretty silly. You're not going to die. Nobody's ever died from it. And this is why I think it's so wonderful. The other thing I've seen, and this is not what I'm recommending, but I have seen people with chronic obstructive airways disease, coughing and short of breath, take a marijuana cigarette and smoke it. With a few puffs, they've got relief from their dyspnea. I would prefer to see them using a nebulizer, but that has been something I've witnessed. If you're going to get acute pain and severe pain relief quickly, then inhaling it is probably the best method. And again, using a nebulizer rather than smoking it.
Well, thank you, Ian. As always, you've just been a complete fount of information. I think that from what I've seen, the backlash, particularly over COVID, is not just about doctors being arrogant about not wanting to try these products on their patients. I think that there is a very, very strong push by the pharmaceutical industry to ensure that any doctors who threaten the bio-industrial medical complex are taken down and made examples of, so that the other doctors are too scared to think. And I think it is time for a divorce between medicine and healthcare. Because if medicine means the Hippocratic Oath and saving lives, then healthcare means the exact opposite, given the direction that it seems to be going in. And I do almost despair for the doctors who don't know how to do anything other than follow a protocol, because they seem to have not been taught to think. And I think it's going to take generations before the ability of doctors to be doctors, which is when I trained. It is going to be a long time before we see somebody work out a diagnosis from basic principles, particularly in a complex patient. And the people that I think will teach us will be our patients, because our patients are voting with their feet. And in fact, some of my biggest ivermectin lessons came from patients. I gave one patient 6 tablets, which were 12 milligrams once. And here's a lesson. Don't give a hypoxic patient verbal instructions. Okay. So off she went at 88%. 5 were for her, 1 a day for 5 days. And I wrote it on a piece of paper, which she lost. And 1 was for her husband as prophylaxis. And I phoned her in the morning and said, "How are you?" And she said, "I'm fantastic. I'm completely cured." So I said, "Okay, well, have you taken your other tablet for today?" And she said, "No." I said, "Well, did you give Peter his tablet?" She went, "No." I said, "Well, where are they?" She said, "Well, I thought I had to take the whole lot at once." So she basically went from being sick to absolutely fine. I saw patients inadvertently overdose. And one of the dangers of the regulators stopping this is the patients will go and get the medication themselves, and they will dose themselves without medical supervision. In this case, it proved to be a real advantage because at least 4 of them really overdosed themselves. One of them was a very interesting one, and I may write this case up. He presented to a nurse in a rural area, and at one stage he was saturating at 39% on 10 liters of oxygen. And I've got all these WhatsApps from her at 3 o'clock in the morning saying, "What do I do?" And I said, "There's only 3 things you can still give." Because he was anticoagulated, he'd had steroids, he'd had doxy, zinc, silver. I said, "You can give him, you can't kill him with silver, you can't kill him with ivermectin, and you can give more steroids." So she gave more steroids. He had 300 milligrams of ivermectin over about a 26-hour period.
Oh.
And the ambulance eventually arrived 26 hours after she called it. And by the time he got to hospital, he was saturating at 75% on room air. So he was admitted to a normal ward and was terribly boring. But, you know, when we're dealing with such safe substances, we can only think the worst of the regulators and who controls them for criminalizing, suspending, persecuting, booting off to court doctors who actually try and save lives.
Yes. No, I agree with you, Jackie. The same here. We've had suspended doctors. In fact, I had Cara Thomas, the secretary of AMPS, the Australian Medical Professional Society, which is the competition to the AMA, and they're the good doctors. Many of them have been suspended, fighting for their rights. She stayed with me for the weekend, and we went to the College of Nutritional Medicine's long COVID conference, collecting members who want to be protected, and bring them all into the fold, so that we, as you said before, it's going to be generational to see the changes, but we've got to start doing something with the good doctors now who want to have a better life and a better way of looking after their patients. You know, you're quite right. It is sinister, and I've said basically it's a form of slaughter. What's been happening when you withhold valuable treatments, and hopefully our media here may start to wake up to what's been happening. There are some signs, but it's still very, very early days. But one of the things I was going to say before, Jackie, is we set up an organisation here. I might have spoken to you about it before, called the Wellness, the World of Wellness, or the WOW, the WOW, and our cry is "Woo the Who, Wow Now." So we don't want the WHO looking after us, the World Health Organization. We want the world of wellness. And we're trying to educate young people and bring them into the fold so that they can carry with them the changes and the need for foresight and insight into what health is going to look like and well-being is going to look like into the future. So, yeah.
Yeah, so I had a chat to Ben, and I believe you're going to be doing a global he's talking about having sort of global members, and hopefully we will be one of your first global groups. Obviously for people who are injured or who need help in Australia, it may be easier for them to get help from doctors outside the country, and so as to not put the doctors inside the country at risk. So we're certainly looking into that, and ways and means that we can collaborate between Australia and Africa.
Yes. Well, I think have I sent you the invitation to be a member of our board of advisory board on the WOW?
Yes, you have. Yes, you have.
Okay. Have you responded with a photo and your bio?
I have.
Okay.
You even complimented me on the fact that I was clearly biting my lip in the
photo. That was brilliant. Yeah. That's the most insightful, thoughtful portrait I've ever seen. Yeah.
That was, I am going to either bite my lip or strangle the person I'm speaking to.
Bite your lip.
Good to speak to you, Ian. And this will go out tomorrow evening, 6:30, and I'll send you the YouTube link.
Thanks, Jackie, and take care. Look after yourself. Look after